Hello, this is Robert Lee, and this is a brief video outlining the use of androgen deprivation therapy plus radiotherapy in men with high-risk prostate cancer. This talk is divided into three sections. The first will include those randomized trials comparing hormonal therapy plus or minus radiation therapy. The second will include those men treated with everyone gets radiation therapy plus or minus hormonal therapy, in which case there's a no hormone arm, so hormones on one arm, no hormones on the other. And then finally, those trials that compare different durations of hormonal therapy. So hormonal therapy on both arms, but the arms differ according to the duration of hormonal therapy. These are the high-risk and very high-risk categories used by the NCCN in 2020. Some also look at the lower end of high risk and describe a favorable high risk category, which is basically non-palpable disease with Gleason 8 cancer or a high PSA but a low Gleason score. This is the first of the many studies we'll look at. Basically, men with T3 disease or high grade non-palpable or palpable disease. The control arm is LHRH plus flutamide until progression. The experimental arm is the same androgen suppression therapy plus local regional radiotherapy to 70 Gray. The primary endpoint was overall mortality. Overall mortality was improved with 70 Gray of radiotherapy. This is one of the few examples where radiotherapy itself is associated with an improvement in overall survival. So there is a dose response here, but the dose response is 70 Gray is better than nothing. A similar study, locally advanced prostate cancer, now 1,200 patients, ADT alone versus ADT plus radiotherapy by conventional standards, low doses, 65 to 69 Gray. In the NCI Canada study, there was an overall survival improvement in those men who were treated with radiotherapy, very similar to the Scandinavian study. So we know from these two studies that in men with locally advanced disease, radiotherapy improves survival when added to androgen deprivation. Now we move to those studies that compare radiotherapy in both arms with hormonal therapy on one arm and no hormones on the other arm. This is the first, what I call BOLA-1, EORTC study, men with locally advanced disease, T3 and T4 disease. Control arm is 65 to 70 Gray alone. Experimental arm is the same radiotherapy plus 3 years of adjuvant GnRH. 400 patients. Overall survival advantage for those men treated with both hormonal therapy and radiation. You can see the hazard ratio there. Quite a significant improvement, an absolute risk improvement of 18% at 10 years. In the United States and North America, 8531 was going on about the same time. This took men with postoperative high-risk prostate cancer, so positive margins, seminal vesicles, or lymph node involvement, or clinical T3 disease. Again, comparing radiation to radiation plus hormonal therapy. 1,000 patients for this study. Just as with the BOLA-1 study, there was a survival improvement with the addition of long-term hormonal therapy. Finally, we have 8610, which basically looks at very bulky disease. The tumor had to be greater than 5 by 5 centimeters, so locally advanced radiotherapy alone versus a different strategy. Instead of adjuvant hormonal therapy, it's neoadjuvant 2 months before and 2 months during using a GnRH plus an anti-androgen. This is the overall survival curve. P-value is not quite 0.05, but if you look at the absolute improvement, it's about 8 or 9% at 10 years. And given that it's a relatively small study, I think there's still good evidence for a treatment effect. A difference of 9 percentage points at 10 years. The question then becomes, can we get away with less? We know that long-term hormonal therapy adds something to high-risk prostate cancers treated with radiation, Can we get away with less? This is a large study, RTOG 9202, 1,500 patients, locally advanced disease, comparing essentially the winning arm of RTOG 8610 to the winning arm of RTOG 8531. It's been reported multiple times, most recently with 20 years of follow-up. Disease-free survival, which is the primary endpoint, was improved in those men who were treated with long-term compared to short-term hormonal therapy. Again, this is prostate cancer-specific survival, not overall survival. If you look at overall survival, the difference is much less. If you use a multivariable analysis and adjust the hazard ratio, you can get a p-value of 0.03. But you can see the magnitude of benefit is relatively modest. A similar study, what I call BOLA-2, this is done in Europe through the EORTC, about 1,000 patients. Patients could have non-palpable or T2 disease provided they had node-positive disease or they had locally advanced. A lot of these patients had node-positive disease, and this is basically a comparison of 3 years versus 6 months of hormonal therapy added to radiation. Looking at overall mortality, at 5 years there was a difference between the arms favoring the long-term hormonal therapy, the absolute difference of 4% at 5 years. Again, remember, lots of these patients had lymph node positive disease. Finally, in the comparison of different durations of hormonal therapy, we have PCS4, published now 2 years ago. These men had high-risk disease. It was designed as really a non-inferiority study. Is probably not big enough for that sort of endpoint. Nevertheless, it compares 36 months of hormonal therapy with 18 months of hormonal therapy. The radiotherapy is the same in each arm. When you look at overall survival, it's hard to see much of a difference between 18 months and 36 months of hormonal therapy. So take-home points are radiotherapy added to hormonal therapy in locally advanced high-risk prostate cancer improves overall survival. Androgen deprivation therapy added to radiotherapy improves overall survival. So the bottom line is the combination of hormonal therapy and radiation is superior to either one alone. Long-term hormonal therapy improves overall survival compared to short-term hormonal therapy in most high-risk patients. But in my practice, in selected favorable high-risk patients, I will opt for a shorter course of hormonal therapy because the magnitude of the difference is hard to justify a long term of hormonal therapy, and many of the randomized trials did not include the screen selected patients that we see with non-palpable one-core Gleason 8 disease. Here are the resources from the many randomized trials. Thank you.